It's just like, I guess, alcoholic has to walk down the street and pass a bar without getting a craving for a drink. Drugs are everywhere, especially in, where I live, in areas that I have to travel through. You have people standing on the corners selling drugs openly, calling you if you drive by, they stop your car and offer you different things. Your approach, sometimes with free drugs, they try to steer you into a situation where something's going to trigger you and get you started again. There's a lot of triggers, a tremendous amount of triggers. One of them is a sum of money. If you get your hands on $20 or $50 at one time, that's a hit. There are other things like if you see some of the paraphernalia involved, the smell of matches that you use when you're freebasing. Somebody lights a cigarette around you, you might start thinking about getting high.
Today, Jim is going to the Veterans Administration Hospital in Philadelphia, where Anna Rose Childress wants to know if he can still resist his triggers.
Stress has been this past week in terms of triggers for craving. How has that been for you?
Well, I had one incident where I had to go into an apartment because of flooding for my landlord, and the guy is a crack addict. The equipment was laying around and
right there in your
crack
face.
vials. But it didn't affect me in the same way.
For 8 months now, Jim has been taking part in a very unusual experiment.
Had there been some actual cocaine there, it might have been a different story.
Might have been. That's a pretty powerful cue.
Wow. What a take. Man, it's got a rush to that, man. What a take. Damn. Yeah, man. Cool with me.
He's being exposed to the most intense triggers, while his breathing, heart rate, and skin temperature are measured.
Okay, Jim, are you feeling any high, 1 to 10?
1.
Are you feeling any withdrawal or crash symptoms, 1 to 10?
1.
Jim's body and mind are being made to unlearn some of his own particular triggers.
Okay, Jim, we're ready for today's drug preparation. If you'd be good enough to open the box and continue, please, up to the point of inhalation.
Finally, he actually has to prepare to freebase cocaine.
You'll get into actual ritual of getting high without getting high. Or you'll cook up cocaine, you'll put it in a pipe as if you're going to smoke it, and then they'll take it from you. You'll go through this ritual like 3 times in a row, and then you'll watch a tape, and then you'll do it again. And after doing that, over a period of time, you get desensitized to the point where you can handle these things without the craving because you know you're not going to complete the act.
This was how his body reacted 5 months ago, an especially large drop in temperature. And today?
Okay, still breathing a little more deeply, but the respiration is regular, and the temperature is holding steady, 97. More deeply.
No drop at all.
After his first hookup, his temperature dropped into the upper 70s, so he's still above 95. Significant improvement.
It's taken 20 sessions to suppress Jim's physiological responses, so maybe he can now resist his triggers. After his successful treatment, Jim was able to reunite with his family. He has remained drug-free for over 10 years. Dr. Childress has continued her work at the University of Pennsylvania. This has led to even more effective strategies to prevent relapse.
What we did in the earlier work, as you know, was give patients repeated exposure to cues that reminded them of drug. We did that in a protected setting. We did it over and over and over again until the patient showed reduction in reactivity. And we found, as Jim described in the earlier segment, that it was helpful that patients did find that they had some reduction in their arousal and the kind of craving response that they would have to those cues. When we looked at the entire group of subjects, we also saw that the benefits were not complete And the reason for that was actually pretty straightforward when you think about it. Patients learned that our cues there on the inpatient unit didn't predict cocaine, that they, in fact, were no longer good, reliable reminders of cocaine, and they reduced reactivity. But they knew that the cues around the corner and down the street were still very good predictors of cocaine, and they still often had strong reactions and strong craving in response to those cues. So we decided what we needed to do was something that was clinically smarter, more focused, more informed, not quite so mechanical as just giving people repeated exposure to one set of cues, because we knew that we could probably never bring all the cues that patients had to deal with into the laboratory and do good enough simulations to really get complete benefit, complete transfer. So what we did was set about putting together active strategies that patients could use for combating this craving or arousal state whenever and wherever it was triggered. And so it was a different approach. Instead of trying to garner all the possible cues, bring them in under controlled conditions, and give repeated exposure, we wanted to have an active participatory sort of therapy where the patients would actually learn strategies that they could use whenever they came in contact with the cue. So that's the thing that we've been doing in the time since in terms of behavioral interventions. And we have now a package of active strategies for, we call it coping with craving. And we teach these to patients on an outpatient basis, and they come in to our clinic, and they essentially are having a session with a therapist that might in some ways be very much like an ordinary session. They come in and they talk about a craving episode that's been bothering them. But we systematize a little bit where we ask the patient how they're feeling when they come in at the beginning of the session, and ask them what kind of craving and arousal that they're having after they've described an episode of craving in great detail. And then we teach the active strategy or tool of the day. And we do that for two reasons. We actually want them to have the experience of bringing craving down and reducing it back down to a very comfortable or minimal level right firsthand, so that they have complete experience themselves. And the other reason is we want to do it in a protected setting where they're in the presence of a therapist, so that if they're not successful, that the therapist can step in and make sure that the craving is down to a comfortable level before they leave, because we're doing this as outpatient work.
By the time I came to the treatment center, things were in shambles. I had abandoned my family. I was basically unemployable, and along the way had lost a couple of very good jobs in the radio industry. I was on welfare, and I was running out of money, or I was out of money, and was beginning to even commit petty crimes to support my habit. For me, until I came into into the University of Pennsylvania Treatment Center, I didn't realize that there was a difference between a desire or a craving to smoke crack cocaine and the actual action. They were inseparable from me. One was laid directly on the other, and I had no idea if they were different. And through a variety of different tools, I came to be able to do that here, to learn that here. One of the tools was the relaxation, and the relaxation I did not use in personally in direct response to craving, but rather I use it in the morning and the night as kind of a preemptive strike to kind of keep the craving off of me. One of the tools that worked the best for me was the imagining the dire consequences of using, because clearly as an addict, when you want to get high, what you think about is the pleasure principle of it. The, boy, I can't wait, this is going to happen, it's going to feel like this, I know how it feels, and it's going to be great. After each period of pleasure, it's followed by a period of despair, usually closely following when you run out of your money. And those periods were closer and closer together for me. And at the treatment center, I learned when I had a craving to think it all the way through to the end, which was eventually broke and in some form of humiliation, and sometimes taking part in risky behavior to continue to support your habit. I've been clean and sober for 4.5 years. I eventually began to get better because I knew something bad was going to happen to me. I didn't know if I was going to die or do time in prison, but so I knew my time was up and something bad was going to happen. Right now I feel like my sobriety is very solid, although I continue to take steps today to keep it that way, because although my sobriety is solid, the consequence of any relapse, in my opinion, will be fatal to me. I abandoned my family totally. The for sale sign was on my house, and yet I was back with my wife and daughter. I was able to see my wife through a disease that ended up being fatal, but I was able to end up being there for her. My daughter's 17 years old right now, very well adjusted, and recently received a scholarship to Tulane. I'm back. I was back in my career, and in fact surpassed any success that I had before. And I think it's important to know, because it's could give hope to people.